Hey Tribe, good evening. I am so happy that you guys are joining us, and Courtney's here today to talk to us about her love of hospice. Welcome, Courtney.
Thank you. I'm super excited.
Yes, so you've been a hospice nurse for 5 years now, and you love it. Something when you and I were chatting initially, you said that your journey from saving lives to helping patients pass with dignity and care was quite the transition, and it actually just got goosebumps saying that. But I just can't wait to hear what you had to say about the beauty of hospice. So why don't you go ahead and introduce yourself?
So, like she said, my name's Courtney. I've been a hospice nurse it's actually close to 4, but it's going on 5 the more I think about it. I originally started I did home health nursing, then transitioned to hospital nursing where I did cardiac step down, and then just from a whim and trusting of a friend, I got into hospice. And I have fallen in love with it. Something that I thought would be a 6-month little stint, a little lesson in nursing, has turned into what I deem my career now in hospice. Besides that, I really still do. I'm actually getting my master's in nursing education and focusing more on just trying to extend hospice nursing for more, just because I know really nobody really talks about hospice. It's kind of like the black sheep of the nursing family. So I'm trying to break through that stigma that people have of hospice.
That's awesome. You're going back to school for your MSN. That's amazing. Good for you. So, as an icebreaker, I like to always ask what your funniest nursing story is. Do you have one that you would like to share?
So it's so funny because in thinking of all the questions you sent, of course, I was trying to think of what my funniest, and I know there's so many, but then I was trying to think of one specifically to hospice, just because so many people think hospice is about death and dying, and that's the only thing people do.
Sure.
And I kept coming to, I had this sweet little lady, and I miss her dearly. But it was one of my first days in hospice with a new company that I was with, and I was doing hospice visits, checking in on her, and she kept telling me her kitty hurt. But she had like history of dementia. So I was like, what do you mean your kitty hurts? Like, what are we talking about? Like, what about your kitty hurts? And this sweet little, like, less than 100-pound lady, like, looks at me and she goes, no, honey, my explicitive lady part hurts. And I'm like, oh my Lord, got it. Sorry, didn't mean to expand on that conversation. But definitely kind of sidetracked me. And I think that's still one of my favorite stories. I still talk about it to this day with anybody who's new to hospice.
That's hilarious.
Just because you don't know what's going to come out of people's mouths. Like, it's insane.
For sure. Oh, that is hilarious. Okay. So I love icebreakers like that because it totally just, I don't know, it's just amazing. I love it. Okay. When did you realize you had a passion for hospice specifically? You said, you found what you envision as your career going forward. When did that light bulb come on?
I think for me, so like I said, I was originally doing cardiac step down unit. We got all the cardiac patients from ICU, like open heart surgeries when I was in hospital. And I had a friend of mine who got into hospice totally just because she was tired of hospitals. She was tired of nursing bullying that was going on where we were working. And she kind of dragged me along with her. She's like, I really think you have a calling for this. Just give it a shot. She goes, worst comes to worst, you do it for 6 months, you leave. Right. And I said, okay, let's try it. And I did. And it was the first couple of months was terrifying because us as nurses, we go on this whole, like, we're taught to heal, we're taught to take care of, we're taught to get people home and with families. And now all of a sudden I'm sitting here going, I know what the end all be all is. Like, I know these people are going to die no matter what I do. And it took me a while to finally realize there's kind of a beauty in it because I'm taking something that is so traumatic for so many people and I'm giving them a chance to, die the way they want to, not necessarily in a hospital bed or stuck with monitors and beeping and people coming in and out all hours of the day. But they get to do what they want to do, and they get to have people that they want. And I get to kind of facilitate that. And I think it was that switch, that kind of mentality change that made me realize this is more than just letting people die. Like you get the ability to change something that we always say in the current company I'm in, that you don't get a do-over in hospice. Once it's gone, they're gone. You don't get a second chance. And so it's trying to give it your all while it's happening, which I think I
Yeah,
love so much.
that's
Changes
great
how you.
advice. Absolutely.
So yeah, I think it was that kind of switch. I think it's all my patients too. I mean, even my sweet little lady who talks about her kitty, they bring joy to me, even in the end of days. Like, and I think that's what switched it, is because you get to spend so much time with them that you gain a whole nother level of care.
Absolutely. So there was several questions from different people talking about starting in hospice versus getting some preliminary experience. So let's just talk about your previous
Mm-hmm.
experience. Do you feel like something you did in nursing prior really helped prepare you for hospice in general? Because it seemed like a very different world. Did you feel like better prepared with your prior experiences?
I think to an extent, yes. So I think it's kind of a catch-22. I think there are some times where if it's your first job, you're first going to it, you don't have to handle that brain switch of kind of what we call it. You don't go from, oh, this patient's short of breath, let me put O2 on them, let me do a chest x-ray, let me figure out what's going on, to then going, okay, let's do O2, but kind of this is what we expected. What are we really going for?
Yeah.
Um, so I think being a new nurse in that sense is a little bit easier. However, I do think having that experience of ICU or step down or even med surge, where you get to see the disease processes as so many things early on, helps you plan for what you can expect to happen at the end. And I think that's what has really helped me, because I can go, hey, my CHF patient, I know what they've already gone through, and I know kind of what to expect at the end of life as well. So it has helped in that sense. It's just a huge shift in your thought process, essentially.
For sure. That makes a lot of sense. Do you recommend job shadowing? Kara wanted to know, with an agency to make your resume stand out, or is there anything, if you're applying to a hospice position, is there anything that people can do to help their resume stand out?
So I know I did a little bit of just asking around. I know it sounds really kind of weird, but having people in hospice to get your foot in the door helps too.
Okay.
I did some shadowing in nursing school, but really looking back on it, that shadowing is nothing compared to what you really see, because there's no way to time it.
Yeah.
You can shadow somebody for months and they never have a patient die, and you're like, this is really weird. Hospice is about people dying. But you go through phases. I mean, I as a nurse, I still go through phases where I can have months where nobody passes, and then within a couple of days everybody goes, and you're like, that's really bizarre. So shadowing is a little odd in that sense, because you're not going to see everything.
Sure.
I do think a lot with hospice nursing, especially now that I'm kind of more in management and interviewing people for hospice, the biggest thing we look at is just, why are you going into hospice?
Okay.
What is your goal? What is your end all be all? Why do you feel like this is your calling? So we always say, like, what brought you to us? Because it's not very common that people are like, I graduated from nursing school and I want to be in hospice. Like, that rarely happens.
Okay.
And so we always look about why. Like, why really take like an internal reflection and say, this is really what I want to do. Or very common occurrence is, hey, I was with my, grandmother or grandfather when they passed, and the hospice nurse changed everything, and I want to give back. And it's a lot of that type mentality. So shadowing can be helpful. It's not always the greatest, just because of that timing issue, but it's really more about why. Like, why do you want to do it?
That's great input. And those of you who are listening live, if it's echoing, let me know in the comments because Courtney may need to turn her volume down.
I can do that already.
Okay, perfect. I don't know if you could hear it, but I could hear a little bit of echoing.
Yeah, I got it a little bit.
Okay, perfect.
Hopefully
Okay.
that helps it.
So just by our topic of conversation and the little bit that you shared, it sounds like you're doing in-home hospice. Is that right?
So we do a little bit of everything. So we do in-home hospice, we do nursing facilities, like nursing homes or skilled nursing facilities. We can also do personal care homes. And then a big one that we do is in-hospital hospice, which essentially is like your terminal extubation patients.
Mm-hmm.
Patients at the hospice or the hospital can be like, hey, we know this patient's going to pass. Can y'all come in? Y'all start the process, and then we try to get them out of the hospital as quickly as we can to kind of free up that bed. But it's working together within the hospital to make sure that patient's stable before we send them home. So we do have different levels of hospice that we do. A lot of it is in home, especially now with COVID. A lot of nursing facilities are saying, nope, we're got it, we good, we don't need y'all. Including hospitals. Even hospitals are saying that at the moment.
Okay.
So right now it's a lot of in-home, but we do have the ability to do others as well.
So what's the process of training a new nurse, not necessarily a new grad, but anybody new to your hospice unit or agency? I'm not quite sure how to label that, but anyway, new employees, how do you guys train them?
So we train them, we actually do a kind of month-long training.
Okay.
So we do the first week is a lot of shadowing every discipline within the hospice company because we have what we call interdisciplinary teams, which are really kind of prominent within hospice, and they consist of the nurse and the chaplain and the social worker and the hospice aide, which is like our CNAs essentially. So we spend a week where our nurses shadow everybody to get an understanding of what each team can do for a patient.
Mm-hmm.
And then after that, they spend a week with actually myself. I'm currently a nursing preceptor, so I do a lot of the education and teaching about how to chart and how to assess patients, how to determine what is needed, just because there is that shift, including in charting. Like, we all in nursing school are taught to chart from day one. And it's so crazy in hospice because I always tell people, like, I know you want to chart positive things, like patient's doing great today. And I'm like, I don't want that. Like, why is this patient still on hospice? What's going on? So it's changing from positive charting to negative charting, which is, again, a huge kind of shift in how nurses have to think. So it's kind of a lot of that education. And then it's a lot of like one-on-one shadowing, following another nurse who's been out in the field for a while, making sure you feel comfortable because it is a lot of autonomy. You're driving by yourself. You're seeing patients by yourself. You're not in a group of 5, 6 other nurses and, CNAs, and there's case managers running around and doctors running around. I mean, it's you, yourself, and I all day long. And learning how to look at patients where you can go, okay, is this something that I need to let the physician know about? Is it something that we need to tweak some stuff? Or what can I do now while I'm waiting for things? I mean, even simple things of a pharmacy, that was a huge change for me. I went from an IC or a step down ICU where I can get meds within 5-10 minutes. And now all of a sudden I'm waiting 2, 3, 4 hours and going, okay, what do I have in this patient's home right now that I can get a symptom under control before I get this medication? So it's a lot of, I call it like the MacGyver of nursing. A lot of trying to figure out how can I make this wound dressing real quick until I can go back and get what I actually need and come back, or how can I solve this issue before this patient just is not comfortable while I'm waiting for this medication. So it's a lot of just learning of that nature. So that usually takes about 2-3 weeks before you start getting your baby feet going. And then we let them like slowly start going off on their own, but always checking back in. Like, how are you doing? What's going on? What have you seen that you haven't seen before? Or just normal phone calls is saying, hey, this patient is doing this and I'm not used to that. What do I do? And checking in. So usually it's about a month, sometimes 2 months if it's like, I don't want to say a slower learner, but if they're just a little bit unsteady, we take them 2 months. But it's definitely a preceptor type situation. And then, of course, like our nurses always have their go-tos. I mean, we had that in hospitals too, where you have your go-to friend. And we have that still. Like I have my friends that I'd be out in the field going, what do I do? Like, this is so crazy. I don't know what to do here. And they'd be like, have you tried XYZ? So it's kind of giving them the tools, but also trying to be like, go be yourself. Like you'll learn it as you go. You got this type situation.
Right. So Christy asked, how long do you feel like it takes to be confident as a new hospice nurse?
So I did a lot of thinking on this one. I think a solid 6 months.
Okay.
I think it's that 6 month window, even a year, but even then, like I'm 4 years into this and I'm still seeing things that I'm like, I don't know what to do, or I haven't seen this before. But I think 6 months is when you finally get that feel of kind of that shift in mentality, as well as understanding how to do symptom management by yourself on your own and feeling comfortable with it and feeling comfortable in how you present to families and comfort families, because at the end of the day, it's more than just a patient. You have this wild dynamic of family who are going through changes too. I mean, they're not used to loved ones passing away. And so it's trying to make sure that they know, because we might be there for an hour or 2 hours a week, but they're there 24/7. So it's a lot of that education as well. So I think, yeah, definitely 6 months. I would say sometimes a year even.
Okay, good. Someone asked, Felicia, I think it was, asked if you have any good resources that you recommend to your orientees, any books or resources that you like to suggest on the process of dying.
Mm-hmm. So there's a bunch, and actually I have a bunch, and we keep a bunch in our company. There's a few books called, oh, right now, of course, because I'm on here, I can't remember the name of it. It'll come back to me. Oh, Out of My Sight. It's called Out of My Sight. And it's a book we give a lot to families, and they're great for new nurses because it talks about every symptom you are probably going to see, everything from shortness of breath, increased secretions, incontinence, and why you're experiencing those things. So nothing is scary or abnormal to them, which is great. It also explains why they experience those things, so it's not shocking to them.
Good.
But there are a bunch of books, even on Amazon. I mean, you could type in hospice books. I think I own most of them now. That are everything from stories of hospice nurses, because they are everywhere from the good, the bad, the ugly, the scary, the terrifying, the spiritually awakening. There's a bunch of those. But there's a bunch of why we do what we do. Because one of the biggest things I've even seen when I did hospital, like in hospital, so with hospital nurses, I would be like, hey, I need atropine for this patient. And I would have an ICU nurse go, their heart's fine. Why are we doing atropine? I'm like, I'm using it for secretions. And they're like, that doesn't even make sense. I'm like, no, like, give me a second. I'll explain it. Like, hold on. And so then I tell them, and they're like, oh, we don't think about those things. Um, so there's a bunch of books kind of about that too, and about why hospice nurses kind of do what they do and what the purpose behind it is. There's also great websites. Just any most hospice companies, I know like VTOS and all of those, have tons of informational sections on their websites that are more geared towards family but help nurses as well.
Yeah.
Just explaining about the whole process, about who all is coming in and out of your house, or what their roles are and all of those things. So you could, I mean, any hospice company has those as well, which is great.
Awesome. If you think of resources that would be helpful, I can always add them to our chat notes afterwards. So you're welcome to shoot me
Perfect.
later. You don't have to remember them off the top of your head. So are there
No worries.
certifications specifically for hospice? And if you have them, what did you utilize to study?
So for hospice, there is what we call the CHIPN or the CHPN, which is the Certified Hospice and Palliative Nursing. I am actually in the process of getting that. So I am currently studying on top of my master's all about that certification. And with the CHIPN certification, it's more than just patient like symptom management. It's a lot of like rules and regulations, why hospice does certain things the way they do. What are the governing bodies, of course, but then it also entails a lot of symptom management, specifically around a lot of pain management,
Okay.
comfort management, really knowing those bases because that's what we use on a day-to-day basis. So it's a lot of that sort of thing. Also, like how to communicate with people, that's on there a lot because of the fact that it is a different environment. You're not always, I mean, we communicate with the physicians as well, but it's a little bit different in terms of how we kind of handle things. And again, the autonomy that even our physicians give us. So it's a lot of making sure, like, hey, you have autonomy, but let's make sure you're still within your scope of practice because that's important. So it's a lot of those type questions.
Awesome. Okay. Well, good luck in preparing for all of that. You've got so much on your plate. So Michelle wanted to know what a typical day as a hospice nurse looks like. So it's going to look really different based on whether you're in a home or in a hospital setting. So maybe just talk about where you most frequently are as a general rule. Michelle says, I feel like it's my calling, bringing comfort to those at end of life, but I have no idea what the job entails.
So for me, so right now I'm actually mostly in the office, but like when I started off, when I was just not just a case manager, but when I was a case manager, it's a lot of planning ahead of time.
Mm-hmm.
You have your caseload that you have X amount of patients. For us, it's usually about 20, 25 patients that are on your caseload that you see at least once a week. However, like if a patient's declining or anything, we see them more often. We can see them every day. We can see them multiple times a day. So for like a regular hospice day, what I used to do is see all my facility patients first thing in the morning because they didn't care if I woke them up at 7 o'clock, 8 o'clock in the morning. Facilities always had nurses there that I can get report from before I went and checked on patients. And usually they were up anyway, so I can sneak in, check on patients, check on if they have medications. Do they need med refills? Is there any symptoms going on that we need to get under control? Any of those type situations. So I would take care of my facilities first. And then it's kind of scattering my home patients because we all know home people, I mean, we're guests in their home. So I used to always plan out my weeks, not just my days, and be like, hey, this patient wants to be seen on Wednesdays, and this patient wants to be seen on Thursdays, and let's do this. And I would plan around their schedules because at the end of the day, they could tell me no. They could tell me, we don't need you today. We're good today. And it's the same situation for them as my facility patients. It's going in and talking to the families, seeing how things are going, what changes are happening. Is there anything that's scaring you with what's happening? Anything that we haven't discussed in the past that maybe we want to discuss now. I mean, even the other day, we had a patient, mom never had shortness of breath, ever. And all of a sudden, she can't get her breath. And of course, with COVID, that's their first thought is she has COVID. And I'm like, well, wait, hold on. Like, that might not be it. It could be it, but it might not. And it's sitting there and talking and explaining, like, let's talk about this. Let's figure this out. And what's our plan? And what do we need to change? And it's that moment. So in a way, like facility patients, I can knock out pretty quickly because they don't have so many questions because it's full of nurses who you can explain something in your technical term and run out and they're good. Whereas family patients are spending a little bit more time.
Yeah.
So I scatter them throughout my week because of how much time it takes.
Mm-hmm.
And then the end of my day is usually, or was usually, back at home, charting, making phone calls, calling in medications, getting ready for team meetings, because we have meetings every other week. So once bi-weekly, with the physician and the social worker and the chaplain. So making sure I have everything ready to give reports to them. So it seems like a lot, but then you get to spread it out. So it actually isn't too bad.
Okay.
You do have days where it's crazy, and you have a patient who passed, and then you had a patient who fell, and then you had a patient who something crazy is going on and family needs help right away. And so you're like, my whole schedule went out the window. And it's one of those that you have to be okay with that. You have to understand, I might have a day where I'm only going to see 2 people, and then all of a sudden I've seen 7. And it's not that I intended that, but it's just kind of what the cards dealt. So there's good days and bad days, but that's usually generalized what it looks like.
Okay, that's helpful. So if it's your patient and in the middle of the night they're getting close to passing, are you always going to be the one that's called, or do different facilities do that differently? Is there an on-call staff? How do you guys work that?
So we have an on-call staff, which is great. So we have a few people. So we have a triage nurse who their whole job is to answer phone calls, and they do ultimately triage. They're like 911 dispatch. If they can take care of something over the phone by pulling up a patient chart and saying, "Oh, you're short of breath. Let's try this medication, and if it doesn't work, call me back." So they'll try to do as much of that as possible, and then the nurse can follow up the next day.
Okay.
If for some reason they can't do that, we have at least 2 nurses on call every day. So we have our on-call nurse that is what she does 24, well, not 24/7, but she's on call for us at nights,
Okay.
where she's running and making the visits that can't be triaged over the phone, or checking on people who have had a change in symptoms, or who have died, or who need a little extra support. And then we have one of our day shift nurses who are kind of like the backup, because there are some nights, I mean, those full moons even get hospice, where it's like everybody tanks at the exact same time and you need that extra little help. But then we're benefited with, we also have a social worker and a chaplain on call. So if it's something that maybe the family just needs a little extra mental support, then the nurse can say, "Hey, chaplain, can you take care of this for me? Can you go help the family?" So we do have on-call staff. I have seen it in the past. I've had it happen in the past, where you create such a strong bond with the family that they ask you to be the one that goes out when the patient dies. And, if you're okay with that, if that's what you want to do, we can. I've done it before. I've had friends do it before, where you just create that bond and you're like, I don't want anybody else to pronounce this patient. I want to be there.
Yeah.
And it's just something that, again, you can if you want to, you can if you don't. I mean, I have other friends that are like, nope, my time is my time. They passed overnight. It's y'all's problem. And that's fine too. I mean, at the end of the day, it's our mental health as well. So it's definitely understandable, but either way.
Yeah. Speaking of which, I like to ask a hospice I'm sorry, not hospice, a psych background would be helpful.
Yes.
Always.
So much so.
Always.
Yes. No, especially because when you think about it, the majority of hospice patients are Alzheimer's, dementia, those type patients, where, again, like my little lady, you never know what's going to happen. And we've had patients before where we'll get phone call. Okay. Funny story time. I was on call one night and had a patient the cops called us because she was going crazy, because she sundowned really bad, and they were like, we have issues. Can you come out? And I spent a good amount of time taking care of these children, for lack of a better word, that were terrorizing her, and going, there's nothing in this room with you, but they were real to her.
Right.
So I had to kind of go with that. And having a psych background is great. I don't have a psych background, and I had to learn so fast how to get one, because of how much even sundowning patients when they're at home seem to like to sundown just a little bit more, and it helps. It definitely helps.
Well,
And
that's
it helps with families too. I will definitely say that when you're dealing with families at end of life, having a psych background is great.
absolutely. Randy made a comment that he's a hospice chaplain and he just became an RN, so he's super excited to be on your side of things doing hospice nursing.
That's awesome. I'm so glad he joined the nursing side.
No, what an amazing transition. He's going to have so much wealth of knowledge to share with his patients and his
Oh,
fellow
yeah.
workers. So that's exciting. All right. So Dale asked, how do you decompress after a stressful shift? Are there resources available to you?
So there's good ways and bad ways. Let me start it that way.
Yeah.
Starting off my decompress, and it's actually happening over on this side too, is always like a glass of wine helps sometimes.
Yeah.
But even more than that, I started having playlists in my car because you spend so much time in your car driving and spending one-on-one time. Like I have playlists for different events of the day. So like if I've had a really stressful day, I have a stressful playlist. If I have a really, awesome, this was an awesome day, nothing happened, I have that playlist. I even have a playlist that I started when I first started in hospice. Somebody gave me this piece of advice and I love it. But I have a playlist for every patient who died. So
Oh,
I used to ask them, what was your favorite song, or what was the song of your childhood, or what was the song you love listening to right now? And they would tell me their favorite song and I'd add it to the playlist. So I have a playlist of all my patients' favorite songs and it is so diverse. But if I'm just kind of feeling that nostalgic, like I just need to remember why I'm doing this, I have that playlist.
that's
And
such a great idea.
it's great. I love it. And truly it's crazy because I have like Metallica on there. I have old jazz on there. I have classical music. I have westerns on there. Like it is so crazy. And people get in my car and they're like, this playlist makes no sense. I'm like, but it does. So I do that a lot. And then as far as resources, I mean, I use my team. I mean, I have chaplains who I call all the time and be like, help me, like, please help me, help me, help me. My mind is not in the right place, or something is just off, and I really need assistance, or this isn't going to be good.
Yeah.
And that has helped a ton. We also, in my company, have also, sorry, let me readjust real quick, take mental health so importantly.
Good.
So if somebody comes in, like we've had nurses who are like, man, my fourth patient has died in the last 48 hours. It's like, go take a day. Like, don't answer your phone. Don't talk to a patient. We'll cover your patients, but go take a day and just do your thing because it is so important. I mean, it's important to all nurses, but when you're realizing like none of your patients are gonna be around in a year or so, and it's so important to just kind of take that moment and be one with yourself. um, I think that's a great reminder. So it's just kind of finding what works for you, and monitoring it however you need to. Mine has shifted so much from day one. I mean, day one I did not have a playlist and I did horrible things to decompress. Not horrible, but less than perfect.
Yeah.
um, and it's just modifying it to be what you need it to be ultimately, and to get yourself in the right headspace with your patients.
That's good advice. I love the playlist idea. That's brilliant. And I'm so thankful that you feel the comfort to reach out to your chaplains. And I think we all need to find that piece. And different facilities do different things. Some have debriefings and offer different resources. And if they don't, and you feel like it's needed, then you should start it because it is really important.
Exactly. Like we do one resource, and I know a lot of hospices do this. We have it used to be yearly. Now it's twice a year actually, because we love it. But we have memorial services
Oh,
where we
that's
meet on the weekend and we light candles and we talk about patients, and we all get together and we invite families. So we send invites to families of people who have lost loved ones. And it's a chance for us to see them again, and for us to, or them to see us, and to just all get together and say, it's been a rough little time, but let's remember everything that's happened. And so we do that, and it's great. I love it. Our physicians get involved. So our medical directors will come out and sit with us, and our chaplains, our social workers, and the nurses. And it's just a great time to just kind of remember why we're doing what we're doing. So we even do those.
That's
Um,
fantastic.
a lot of places do them. Some of them are yearly, some of them are twice a year. So it just kind of depends. But if it's definitely something that you're in hospice and your company is not doing it, try to get one started. I mean, even if it's just a gathering in your conference room or in your meeting room, sometimes that's where we did it, where it's like, man, this week has really been hard. Can we take 2 seconds and just kind of decompress here?
Yeah, absolutely. Teresa said she does hospice PRN and she's appreciating learning from you. So,
Yay.
what characteristics do you feel like make a nurse specifically successful in hospice? Is there anything that you pinpoint in a nurse that you can look at them and say, you would be phenomenal in hospice?
Okay, so I'm going to try to stay away from the nursing cop out of compassion and caring, and because I think we all have those. I think that is the generalized census. None of us got into nursing because we weren't compassionate and caring. Um, I think there's a different level to it. I think there's a difference between, hey, we're going to do everything in our power to get your mom and dad back on their feet. We're going to get them going. And I think it takes a different level of compassion to be like, hey, what's the end all be all? What's that goal? Do we really want mom and dad strapped to monitors? Nothing against ICU nurses, ER nurses, anything. I praise them because I couldn't do it. Um, but having those harder conversations, you have to have that mindset that you're going to tell people there's no turning back from this. And what are we going to do? And how are we going to make them comfortable? And I feel like that takes a whole different level of compassion because you have to put yourself in their shoes. You have to be able to say, if the tables were reversed, how would I feel? How would I want this to be addressed to me? At the same time, in a really weird way, like I always tell people, if you have a really sick sense of humor, sometimes that helps. Just because of what we do. I mean, that's horrible. It sounds horrible. But having that ability to then, again, it's going back to that decompressing of realizing I'm going to be super compassionate, but then I can have a moment of releasing. I always tell my patients, family members, like, please be glad you're not in a hospice office because it gets a little crazy and a little hairy sometimes. But understanding, like, it's not because we're trying to be mean. It's not because we're trying to be cruel or unusual. It's because we're trying to survive in this field. And unfortunately, so many nurses, I think, I mean, even when I started, I had people go, you're not going to do it, but for 4 or 5 months, and then you'll be back in the hospital. And that was almost 5 years ago. And I think because you have to have that mentality, you have to have that strong, like, mental drive to keep going and being able to say, like, I need a break or I need to stop. And I think that's part of nursing that so many of us don't have or need to work on, myself included, is saying, I need to stop for myself. I need to take care of myself before I can take care of all of these other people. Because at the end of the day, it's not one person. You might have a caseload of 20, 25 people, but that could potentially mean 50, 75, 100 people when you start counting in family members.
Right.
You then have to focus on all of them as well. And that's a lot to take on every week. And it's a lot of dynamics that you have to work with every week across the board. So definitely that strong mental game you have to have.
For sure. We get questions from group members quite frequently about what's the best holistic style of nursing. Do you feel like, this just occurred to me, do you feel like hospice might be a good route for those nurses who are wanting that holistic style of nursing?
Absolutely. Absolutely. I actually, that's kind of my whole focus in my master's program right now, is the idea that hospice really is that epitome of holistic nursing. Because you're going in, and I might spend 15 minutes fixing a symptom or fixing an issue with a physical symptom a patient's having, but I'm then spending 45 minutes to an hour talking about why. Why are we doing this? That whole mind, body, and soul part. We've had patients who have pain like 10 out of 10, and I get them on fentanyl and morphine and increase it to methadone, and it's still 10 out of 10. And you're like, this doesn't make sense. And then you start realizing, wait, this isn't physical pain. Like, let's talk about this. What's going on? And it could be they're dying alone, and that's what's manifesting itself. So then you have to sit there and go, okay, what are you scared of? What are you nervous about? What are we not finishing with? I've had patients before on death's doorstep for weeks, and loved ones are tired and they don't understand why are they still holding on. I had this one sweet little lady one time would not leave, would not let go. And her husband was like, I'm tired. I know she's tired. And it's going, okay, well, let's talk about this. Like, what did she never leave home without? She's leaving. What did she not leave home without? And, for him, he's like, she never left without her purse. We're like, well, let's stick her purse in her bed, see what happens. And she passed 30 minutes later, like she wanted her purse. And it's like, you have to have that mentality of like, what else is going on? And sitting there and using that holistic approach of maybe it's not just a physical symptom that's holding them on. Maybe it's a mental or, anything like that. I really do 100% think hospice is the epitome of holistic nursing care. And I think that's why, for me, it's so important to kind of share what hospice is and say, like, hey, you might not like it, but try it. Because you can learn a whole lot about that whole holistic approach.
That's amazing. I love that person, the bed story. Um, I feel like so many times, and we've talked about this in the Tribar and Facebook group before, but how many of us said, I would never do that. I would never do this nursing or that nursing. And lo and behold, you try it and you fall in
Mm-hmm.
love, right? And like you're
Mm-hmm.
saying, I foresee that being my career moving forward. How many of us have said that about a certain path and we find ourselves on it and realize that it is the path for us? It's so cool.
Yeah. I mean, I started off trying to be like an EMT, a paramedic. That was what I wanted to do. I was the epitome of adrenaline junkie. Like, I wanted to do that trauma and be in that ICU. And it's so funny where your road takes you and you're like, I'm good. I mean, I still get my adrenaline rush occasionally because you never know what patients are going to do. But it's so funny where, just trusting a friend or trusting an instinct or saying, I just want to see you. I had a friend, or I work with a friend who did hospice just so she could learn the end of life process, so she could educate families in ICU about what it looks like. And she hasn't returned. I mean, she's still in hospice and she loves it. And she goes, I never thought that this would happen. It just kind of did. And I think that's a great thing about trying out things and being able to kind of see what else is out there.
It's the beauty of nursing, isn't it?
Yes, absolutely. There's something for everybody.
Yeah, absolutely. So we had two people, Josephina and Kara, and we just want to know, what do you love most about hospice?
I think I love my families the most. Like 100%. I love my families. You get to learn so much about people when you're coming in and out of their house all day long. Um, and sitting and talking to them. I've met a sweet little man who was on a battleship in Pearl Harbor. I mean, I met a person who was in Germany during the Nazi regime and got shot by a Russian soldier. And sitting there and talking to them, you get to learn so much about other things. And not only that, but you get to learn their impact on their families. Um, you get to hear from their daughters and their sons and their spouses. I mean, all the little old spouses that are married 60 plus years, and you're like, what's the secret? Because I'm on year 5. Like, how do I keep going? Um, it's those mentality, and you build such a relationship um, that it's changing. I mean, it changes you. I've had families where they knew I was always going to be there on Wednesdays at 8 o'clock, and they had a cup of coffee waiting for me. I
Aww.
mean, it's those things. You build those relationships that you don't necessarily build completely in the hospital. I mean, we've had those in the hospital too, but it's different when it's on their terms. It's on their turf. It's in their home. So you build that different kind of idea about what they need or do. And that's my favorite thing. You don't get that anywhere else. And that's what I truly do appreciate about hospice.
That's really cool. Chelsea asked a question about how to deal emotionally with families who aren't able to cope with losing their loved ones. How do you do that?
Time, a lot of time, a lot of teamwork. It goes back to using every part of your team, your social worker, your chaplain, in time, slowly kind of building on that, not being upfront and going, your loved one's going to die tomorrow, or not, well, not tomorrow, but like your loved one's going to die in a month, but more kind of building on what are you hoping to get? What would they want? Instead of pushing your feelings onto something, what would they want? And I think it's those conversations that are, again, hard to have, but they're important. And sometimes it's so good to get that chaplain and that social worker involved, because they might have a different personality or a different kind of viewpoint. I have one chaplain. I love her. I could not do it without her, but she is that one who has those hard conversations all the time, and she loves it. She adores it. And every time I hear her, I learn something new. But it's definitely that whole timing process. Are there going to be families where you never get them on board? Yes. Unfortunately, they come. Unfortunately, it happens. Unfortunately, you get that family dynamic where maybe the son was wanting it, but this daughter isn't. And you're going to have those fights and those arguments. But at the end of the day, it's kind of pushing through and being that patient advocate of saying, what would mom or dad want? What would your grandmother want? It doesn't matter about what you want. I mean, yes, you need to be comfortable with it too, but at the end of the day, you're still going on. So what do they want? And it's that kind of idea. I mean, there's going to be losing battles. I've had them. I've had people scream at me because mom and dad died. I'm like, but it's kind of pushing through that again and saying that unfortunately that's part of it. But it happens. But definitely using your team. Your team is your biggest asset in hospice. Every single one of them is. And even your other nurses, because you have nurses who have done this for multiple years, and you have nurses who are new to it, and using them and even using their personalities, because the way I educate might not be the same way my coworker educates. It's all finding that right personality and that right framework.
That's awesome. Josephina and Kara also wanted to know, what's the hardest part of your job?
Losing those you really don't want to lose. And that has happened so many times to me. You get a little too attached. Mm-hmm. You try to put boundaries up, you try to stop yourself, and sometimes you can't. It's sometimes like I've had patients where it's gut wrenching, because you could have a patient, you're their only family member, you're the only one there, and it's hard. And it's hard to kind of be that one person, and then you get so attached because you are that one person. And then when they go, you miss it. I mean, you miss that companionship, you miss those conversations. And it's hard. It really is. I mean, you do have those patients that you're like, we finally got them comfortable. They're finally resting. They're not hurting. But then you get those. I mean, we've had 23-year-olds, 35-year-olds. They come few and far between, but they kind of put a check in your set, like your own personal stuff, because, you're not far from that. Like, I'm not that far from 35. And here I am taking care of a 35-year-old.
Right.
And that's the hardest part. And unfortunately, I mean, none of us can, it's the cards we're dealt, but it definitely is hard. And looking at how some people live is hard. I mean, you're seeing them not in a hospital room where we have full control over what we see, but we're seeing kind of what they're in 24/7. And sometimes you can't stop it. And that is what gets hard.
That would be hard.
Yeah. Yep. I've had the hoarders, I've had the roaches, and I'm like, I can't, and I want so badly to steal them away from there and take them home, and unfortunately I can't do that. Yeah. But it's hard. It's definitely hard.
Yeah, for sure. So you're back in school for your master's, and yes. What are you most looking forward to in your career moving forward?
Mostly a lot more of this. I really like, again, it's that whole kind of what we talked about in our emails is I'm excited to share, try to push off that stigma of hospice. I feel like so many people are scared of it. I've been called a Grim Reaper before. I've been called the Angel of Death before. And I feel like it's so much, I mean, yes, that's what we do, but it's so much more than that. And I feel like pushing that stigma where it's not so scary and it's not so terrifying is so important, especially now that, I mean, Medicare and the government's kind of pushing for hospice a little bit more, um, which I'm super excited about. I'm kind of watching how it kind of forms and what happens with it because hospice still is relatively new in the nursing world. I mean, it's not super brand new, but it's still relatively new. So I'm super excited to see what happens to it and where it goes and how much it grows. I mean, hospice is continually growing, and like all of nursing, it's not going to go away. People die every day, and seeing how things change from that. And I'm hoping, like, on the nursing standpoint of trying to prove that it is more than just sitting there and watching somebody die. Like, you are doing nursing things. You're still providing that comfort and that care, and getting more people interested is, I think, my biggest kind of goal. And I think that's what I'm super excited about.
You know what? I love the whole idea of it being more holistic in nature. My aunt passed. She had pancreatic cancer and it metastasized and all the things. And she was cared for by my other aunt. I tried to talk them into hospice, and I tried to get my other aunt on board, and she was so hesitant. I'm not giving up on her. I'm not giving up on her. And I know you've heard that a zillion times.
Yes.
I didn't have the right words that she could hear what I was saying,
Mm-hmm.
that she wasn't giving up on her. What is your favorite tip and trick for those family members who are not going to give up on their loved ones, so they're not going to do hospice? What is your perspective, and how do you work them through that?
I think it's shifting their thought process. You're not giving up on them. I mean, unfortunately, doctors sometimes are going to come in and tell you there's nothing more they can do. I mean, you can have a heart patient who's 99 years old and no surgeon is going to do open heart surgery, or you're going to have those cancer patients where despite every possible treatment, nothing is responding to it.
Mm-hmm.
And I think it's shifting that mentality of saying you're not giving up on them, but you're preventing, like, this is a chance for you to let them be comfortable and let them be where they want to be. And they get to dictate what their end of life looks like.
Yeah.
They get to dictate what those last days get to be like. Whether that be, yes, you're going to have patients, even on hospice, who are like, this is not what I want. Take me to the hospital, stick me up. Like, I want monitors, I want the whole thing. And that's fine. That's their choice. That's what they want to do. But then you have those that are like, I want to be in my bed. I want to be with my dog or my cats or surrounded by family,
Mm-hmm.
not hooked up to beeping. Like, and if that's what they want, that's great. And I think that's something I know with hospice. My family laughs at me because prior to hospice, I didn't care anything about, wills and last wishes or anything like that. And now I have every family member's plan because it's having those conversations early on and saying, hey, what do you really want? And I think that's a big thing that some of my friends who are still in the hospital, and they tell me about their frequent flyers that are like their 10th time for CHF exacerbation or their 10th time for COPD exacerbation. I kind of tell them, like, hey, start talking about hospice. Don't tell them that it's time yet. Don't do that. Don't tell them they're going to hospice right now, but ask them what they want their death to look like. If they could say right now, when they're A&O times 3 or 4, able to make their decisions, how do they want to die? This is your chance to determine that. And it's my role as a hospice nurse to make that happen. And I think that's the biggest thing that we tell our families is you're not giving up on them. You're giving them that final say. You're giving them that final chance to determine what they get to do.
Yeah.
And however that is. I mean, I've had weird requests, but I will do whatever it takes to make them happen. because that's their final say. And I think that's what's so important. And I think that's a conversation that a lot of people need to have with people early on, not when they're given that 6 month or less kind of life sentence. I mean, because that is hospice. It's 6 months or less realistically. And it's having those conversations beforehand and saying, what do you want? What do you desire? And then how can I make that happen?
Yeah, I read an article probably within the last 6 months of a hospice patient who wanted to go, I think it was to the ocean or to the lake, one last time before they died. So the staff made a pool out in the yard of the facility that he was at. And they took him to this pool and they lowered him in. And it was really funny to me because people were making comments on this video. It wasn't an article, it was a video. We're making comments like, oh, that doesn't look safe. Talk about fall risk. And I'm like, guys, this is his last wish. He's a patient. Like, yes, rock on. I love this, So I love what you guys do and just the heart and soul you pour into these last days, weeks, months, whatever it is.
Yeah.
I love it.
I mean, it's the same thing. Like I used to get in so much, not trouble. It wasn't trouble within my company, but like trouble within my nursing friends because I would take a pack of cigarettes to a patient on hospice for lung cancer. And I'm like, what is this pack? Like the damage already is done. Like I'm not going to put her through smoking since like make her stop smoking at the end of life because now's the time to do it. Nope, we've already passed that point. Right. I actually, funny story, helped a guy find a stripper because the last thing he wanted to see before he died was boobs, and he was by himself, and that was the only thing he wanted. So those were weird phone calls that I made, but I did it because that's what he wanted.
That's
so
fun.
It's that mentality of like, I'm going to do whatever it takes to make my patients happy. I have patients who want to smoke marijuana. Go for it. Like, who's going to stop you at this point? I mean, you're on hospice. I'm not going to tell you not to do something. I'm going to kind of help you make sure you're doing it in a safe way so you don't speed up your timer even more. But I mean, I'm not going to go through that process of making sure. Now, I do fall risk and all those things, but you got to do what's best for them and what makes them happy in that end of life. And that's what at the end of the day is the most rewarding.
That's awesome. Well, I appreciate you joining us after your long shift at work. I love all the insight and education you provided for us. And I am so thankful that you've joined us this evening. So everybody that tuned in, thank you and have a great night.
Thank you.
See ya.